At the outset, I thank the organizers for giving us the opportunity to chair this session. And as you know, IEM is always a nightmare for a pediatrician, neonatologist especially. And I think my friend Dr. Mohandas will help you to tackle the situation easily. Over to Mohandas.
So just one second before starting your session, we have 20-minute session, first bell at 18 minutes. Thank you.
I would like to thank the organizers for giving me this opportunity, and thanks for Dr. Shankar for the nice words. I think it is not required to tell what is the definition of IEM. All the IEMs are inherited disorders, so the better term now is inherited metabolic disorders. And mainly it is because of some block in a metabolic pathway, and maybe due to the deficiency of certain enzymes, so that certain substrates are accumulated or certain products are reduced, or due to some alternate pathway, certain metabolites are synthesized more. And there will be manifestation of certain deficiency or excess of certain metabolites. So there are more than 500 conditions. They are individually rare, but as a group, they are as common as the common condition we see, Down syndrome. But we don't see IEM that frequently, because a child having Down syndrome we see several times, whereas IEM may not that frequently. Many of them die in early infancy itself. So if not properly identified in time, it leads on to permanent disability or death. And many of them are treatable, and outcome depends on how early and effectively you manage. And they can have life-threatening crisis at any time. And another important factor is the recurrence risk in subsequent pregnancies, because majority are autosomal recessive conditions. With proper screening, management before becoming symptomatic, and prenatal diagnosis by proper counseling and workup. Now IAP is working hard to reduce the IMR, and in Kerala is having the lowest IMR, and now for further reduction in IMR, we have to concentrate on such situations where we can, with the proper prenatal diagnosis, we can avoid birth of a child who are likely to die in the early infancy. So we can go through a case which we had recently. It's a female child, birth weight 3 kg, born unasphyxiated, a second child of third-degree consanguineous parents. They had lost their first baby in the newborn period, born unasphyxiated, was feeding well on day 1, started vomiting on day 2, poor feeding from day 3, hypoglycemic seizures on day 3, and managed as sepsis. Many investigations were favoring sepsis, and the baby died on day 7. And this baby also had similar symptoms. So there were several features to suspect IEM in the second child, or even in the first child itself. So when to suspect IEM? Whenever a baby is having poor feeding, lethargy, convulsions, or vomiting, especially after a period of normalcy, and when there is consanguinity or previous sibling death, you should be highly thinking about such problems. And some of the conditions can have peculiar odor, body odor, or urine, odor to urine. And again, if you have high index of suspicion, you can think in most of the critically ill newborns, any child having neurodegeneration, mental retardation, coarse or dysmorphic face, parenchymal liver disease, organomegaly, cardiomyopathy, corneal opacity, lens dislocation, cataract, unexplained acidosis, hyperammonemia, hypoglycemia, failure to throw. So the situation where we have to suspect IEM is very broad. And certain clinical clues, apart from abnormal body odor I have mentioned, Some of the conditions are characterized by hypopigmented skin or hair. The well-known example is PKU. We don't see many number of PKUs in our area. MSUD is fairly common compared to PKU, I think. And MSUD also are very having hypopigmented skin and hair. Then large head and subdural hemorrhage. You can suspect glutaric aciduria type 1. That again is relatively common among IEMs. Seborrheic dermatitis in a child where you think of IEM, consider biotinidase deficiency, which is very important to suspect biotinidase deficiency because if you identify it early and it can be treated just like we treat hypothyroidism with tablets. Then spasticity or diplegia, you can get an arginase deficiency. And black urine, if an urine is kept for some time, blackening in alkaptonuria. Then conditions presenting, so different IEMs have different mode of presentation. Conditions presenting as encephalopathy with or without metabolic acidosis or organic acidemias, urea cycle defects, congenital lactic acidosis. And some conditions presenting with intractable seizures are pyridoxine dependency, non-ketotic hyperglycinemia, which can even the seizure can start in utero, which is appreciated as increased fetal movements, molybdenum cofactor deficiency, folinic acid responsive seizures. Then conditions presenting as acute liver disease, jaundice alone in Gilbert or Krigler-Najjar, hepatic failure in galactosemia, tyrosinemia, GSD type 4, neonatal hemochromatosis, presenting as cholestasis in alpha-1 antitrypsin deficiency, Niemann-Pick type 3, persistent and severe hypoglycemia in galactosemia, GSDs, fatty acid oxidation defects, organic acidemias, disorders of gluconeogenesis, and hepatomegaly along with cardiomegaly, muscle weakness in Pompe disease. Then presenting as muscle dysfunction like myopathy, progressive myopathy in Pompe, exercise intolerance with cramps and myoglobinuria in GSD 5 or 6. As part of multisystem disease, myopathy can occur in mitochondrial myopathies. Conditions presenting with cardiac manifestations in fatty acid oxidation defects, mitochondrial disorders, GSD type 2 Pompe, methylmalonic aciduria, Fabry disease, Kearns-Sayre syndrome. Usually IEM, the babies are having normal facies. Very rarely, some conditions can be associated with the dysmorphic facies like Zellweger syndrome, glutaric aciduria type 2, and various lysosomal storage diseases, there will be dysmorphism. Some conditions will have predominant renal manifestations, RTA in cystinosis, galactosemia, hereditary fructose intolerance, and tyrosinemia. So with the specific symptom complex, you can think of certain conditions. So you can narrow down the differential diagnosis. And based on a properly drawn pedigree, you can, because all of them are inherited disorders, majority are autosomal recessive, but a few are X-linked recessive, like ornithine trans carbamylase deficiency. So in such cases, a 3-generation pedigree focusing on the maternal side is very important. Autosomal dominant also is possible as in acute intermittent porphyria. Mitochondrial inheritance is there in conditions like Leigh disease. Then confirming the diagnosis is very important. Many of them can mimic sepsis, as the example I quoted initially. Elevated CRP and low total count and neutropenia are possible in organic acidemias. Cerebral palsy, intrauterine infections, other cause of acute encephalitic syndromes or acute liver failure can be differential diagnosis depending upon the situation. So usually when you think about IEM, you have to do minimum blood sugar, urine ketone bodies, blood ketones, serum lactate, blood gas analysis, and plasma ammonia, which will guide you to which direction you have to proceed. And depending on the condition suspected, based on the findings in the initial testing, further workup is planned, along with working upon other differential diagnosis. It may not be IEM always. In the case I was mentioning, this baby had hypoglycemia, but with the correction of blood sugar, the clinical condition did not improve. Blood gas analysis showed acidosis. Urine ketone bodies was positive. Plasma ammonia was moderately elevated. And some of the conditions you get a clue from brain imaging. For example, in Zellweger syndrome, there is a peculiar finding. Agenesis of corpus callosum seen in pyruvate decarboxylase deficiency, Menkes, non-ketotic hyperglycemia. MSUD, you have brainstem and cerebellar edema. Subdural hematomas and frontotemporal atrophy suggest glutaric aciduria. And MR spectroscopy, which is considered as chemical autopsy of the brain, you can have certain peculiar findings in certain conditions, especially conditions like Leigh disease. This is one MRI of a child having glutaric aciduria, where you can have very characteristic bat wing appearance because of the atrophy of the frontal part of the cortex. And you can see the deep sylvian fissure also. And in our case, MRI had suggested MSUD because of the edema of the brainstem area. Then you can confirm the diagnosis by doing tandem mass spectrometry or urine GCMS, which is simple test done on dried blood spot, gives lot of information. It's a broad spectrum. Many IEMs you can get clue. And it is useful as a screening tool also. Samples are easy to transport and fairly fast reports are available. If positive, it is helpful in making diagnosis, but if negative, it does not rule out all IEMs. And it is useful in follow-up also. You can assess the metabolites, whether it is adequately controlled, and you can modify the dietary modification or medications based on the follow-up TMS. So many conditions can be diagnosed from TMS, and it is used as the major screening method for IEMs. And in our case, TMS showed elevated levels of blood valine, leucine, isoleucine, and isoalloleucine, and low levels of alanine, which was suggestive of MSUD. And this child, we could not appreciate any unusual order, even though it is mentioned. In most of the case of MSUD, there will be that unmistakable order. And the urine gas chromatography mass spectrometer, or GCMS, is another test which helps, along with the TMS, to identify the condition. And next important step is to have a molecular diagnosis, which is not essential for clinical management. For clinical management, whatever we have done so far is sufficient. You can treat this child as MSUD, but it is more important in prenatal diagnosis. Clinical exome or whole exome or specific panels are there, IEM panels are there. The diagnosis becomes more authentic also, because sometimes the parents may not be convinced that child needs a lifelong treatment. So to convince them, sometimes this test will help. And the cost, compared to the previous days, the cost is now coming down. And in our case, we did the clinical exome, and it showed the mutation, in homozygous state, and they have mentioned it as pathogenic. So this particular mutation is already known to cause MSUD. So this case confirmed beyond doubt that it is MSUD, and now we have the data to help the family to avoid one more child having the same problem. And immediate interventions, you have to, the reduction in substrate accumulation, reduce accumulated toxic metabolites, supplement deficient metabolite, enhance deficient enzyme activity, adequate energy as 10% dextrosin saline or intralipid, except in cases of fatty acid oxidation. In most of the protein IEMs related to protein metabolism, you have to supply energy either as 10% dextrose or intralipid. Avoid dietary or parenteral intake of potentially toxic substances, and correct metabolic acidosis, dehydration, and electrolyte imbalance. These are the important steps in the management. and enhance the excretion of toxic metabolite. Hemodialysis, peritoneal dialysis, or exchange transfusion may be helpful. Empiric cofactor or coenzyme therapy or carnitine in indicated cases, and prompt control of infections, fever, or other stressful conditions are important in managing that case. And in our case, the hypoglycemia corrected, calories provided by 10% dextrose saline, oral feeds withheld, all proteins stopped. And even though the hemodialysis said to be better, because of some logistic problems, we did exchange transfusion in this baby, and the baby improved markedly, and furosemide was given to reduce the cerebral edema. And regarding the specific management, specific dietary formula are available for certain conditions like glutaric aciduria, phenylketonuria, MSUD. Previously, it was considered as a food item which has to be imported, and the price was very high. Now it is available in our country also, and the pricing is relatively has come down. And in our case of MSUD, we put on special formula, and initially the child was only on this special formula. And we know a particular essential amino acid is deficient in this special formula, so that the protein synthesis will not take place at all. The baby was losing weight for the next few weeks, and then the baby was given in a 50-50 ratio, the breastfeeds and the formula, and then the baby started gaining weight. And so you have to provide the normal protein also to ensure growth. And the ratio has to be titrated based on the weight gain, control of symptoms, and based on investigations like plasma, amino acid levels and all. And after a particular age, you can maintain them on protein restricted diet. For example, in glutaric aciduria type 1, it is said that up to 6 years you have to give the special formula. After that, a low protein diet will be sufficient. Metabolic crisis should be anticipated and managed energetically to prevent end organ damage. And this baby is now doing well, gaining weight and developing normally. And there are certain curative interventions also possible, like hematopoietic stem cell transplantation, liver transplantation, gene therapy. Even though we are discussing about it for a long time, it is still experimental in these conditions. And conditions like biotin-based deficiency, I have mentioned, you can easily treat with a tablet biotin, lifelong. And you have to be prepared for prenatal diagnosis. You have to work up the index case thoroughly. If the baby dies before having the diagnosis, you have to keep samples, especially EDTA sample, for further workup. And now the government is also giving more stress to rare diseases, and government of Kerala is planning to support the families having rare diseases. Government is willing to procure the special formula for the family. We have already mentioned that Kerala is trying to reduce infant mortality further, and if we want to reduce it further, we have to screen this sort of conditions at birth itself by doing tandem mass spectrometry. Now we are screening only very selected conditions, but many developed countries do screening for several conditions, more than 29, 30 or so conditions. So tandem mass spectrometry will be very helpful in screening, identifying these conditions before they develop symptoms, and we can manage and also help the family to avoid birth of one more affected child. Thank you.